Good afternoon, everyone. My name is Kathy Ottenhoff, and I'm one of the BORN coordinators. On behalf of BORN Ontario, I'd like to welcome you to our provincial rounds for a BORN update on congenital anomaly collection, data quality, and surveillance initiatives. A question and answer period will occur at the end of the presentation. Please feel free to type your question into the chat box in the lower left-hand corner of your screen. And as you have heard, these rounds are being recorded and will be posted to the BORN Ontario website. I'm very pleased to have three of my colleagues from BORN presenting today, Heather Ramshaw, Erin Graves, and Chantal Wright. Heather joined BORN Ontario as a Congenital Anomalies Coordinator in October 2011. She works out of the research offices of Dr. Graham Smith here in Kingston. Heather is a resource person for the Ontario Congenital Anomalies Committee and represents Ontario on the Public Health Agency of Canada Congenital Anomaly Surveillance Project. Erin started at BORN Ontario as an epidemiologist in October 2012. She works with Heather as a resource person for the Ontario Congenital Anomalies Committee and as well has served on several ongoing data quality projects at BORN. Chantal came to BORN Ontario as a quality management specialist in July 2014. She has a great understanding of the full scope of data quality from a start doing data entry in a hospital's emergency room to experience ensuring privacy while processing freedom of information releases on medical records through to completion of the Masters in Health Administration with a residency project involving external stakeholder engagement and feedback. So I'd like to welcome all of you and welcome to Heather, Erin, and Chantal.
Good afternoon, everyone. This is Heather. Erin, Chantal, and I will be taking turns doing a few different components of this presentation. So as Kathy said, we're here to give an update on congenital anomalies collection, data quality, and surveillance initiatives. The objectives for this provincial round will be to provide an overview of the BORN information system activity since the last update. Since everybody, I'm sure, had a great summer, we just wanted to give you a little refresher. Give a general data quality review, provide a basic overview of congenital anomalies, and then outline provincial and national congenital anomaly surveillance initiatives. Finally, review the data collection and quality of congenital anomalies collected in the BIS. So we'll get started. Since the BORN information system was launched in January 2012, the system has now been live for over 960 days. So with 2.5 years of experience in collecting data, we are at the point where we can make a difference in the information that has been provided to us by hospitals, midwifery groups, labs, and other participants in the system, and this includes our anomaly data. In Ontario, there are over 140,000 births every year. As of September 2014, there have been over 635,000 births captured in the BORN information system, and this is after historical data was entered for 2011-2012. Following birth, as you know, all children in Ontario are offered the newborn screening, which tests for 29 rare diseases from blood spots that are sent to the Newborn Screening Ontario. In fact, the BIS has managed to identify over 1,300 babies that did not receive the opportunity for this screen. The data captured allows us to identify those children and go back and address the problem. Other BIS highlights include the launch of the BIS in the provincial fertility clinics in January 2013, and data entered for over 3,500 antenatal specialty visits on cases where fetal anomalies were detected, all prenatal screening results from 5 labs, all level 2 NICU stays, and approximately 50% of the level 3, and prenatal and newborn screening follow-up results from clinics. There are over 7,000 system users across the 400 organizations. Data is entered by nurses, clinicians, medical staff, medical records staff, lab technologists, clerks, and family health teams. It is the effort of all those involved in getting high-quality data into the system that allows us to start using the data and identifying some of the gaps. Chantal will now provide a data quality review.
Great, thank you, Heather. So I'm now going to review how information is entered into the BORN information system, who uses the data once it's entered. I'll then go over the BORN data quality framework and its dimensions, and give examples of BIS features and functions that optimize data quality. So how is information entered? Generally, patient information is entered by nurses, midwives, and clerks in hospitals and clinics, and lab technicians. Information is entered into the BIS two different ways, either via manual entry, where information from the patient's chart is entered directly into the BIS, or via electric upload from the information systems installed in healthcare sites, such as hospitals, clinics, and labs. Examples of these are OBTV, OBIX, and Meditech. Who uses the data? So we have hospitals and care providers, which include directors, program managers, educators, decision support health informatics teams, and physicians and midwives. We also have government and policy developers, which include the Ministry of Health and Long-Term Care, Health Quality Ontario, and the Provincial Council for Maternal and Child Health. We also have PHUs, local health integration networks, so all 14 LHINs across Ontario, many researchers, BORN Central, and many professional associations and special interest groups, such as the Society of Obstetricians and Gynecologists and the Association of Ontario Midwives. So what is the BORN data used for? It's used to examine health services issues, performance measurements. We use it to trend over time, continuous quality improvement initiatives, policy development, evidence-based decision-making, supporting public health programming, informing research questions, and generating perinatal and neonatal reports. An example of one of these reports was a LHIN report that BORN created a few years ago, where it was used for information and useful guiding policy decisions for maternal and newborn issues in every region across the province. On an individual or patient level, BORN provides patient summaries and reminders at discharge. So these infant summaries are also used as follow-up for pediatricians or family physicians. And BORN can also identify patients who didn't receive key interventions and provide reminders, such as the Newborn Screening Ontario that Heather mentioned earlier, where we can identify patients who were not tested. It's very important to note that data entry does not necessarily mean that the correct information has been entered. BORN has quality projects in place, such as re-abstraction projects, to determine the quality of the information that's entered into the BIS. We also have many reports so that sites can also reconcile their data. So I just want to go over BORN's data quality framework. At BORN Ontario, we make data quality one of our highest priorities, along with privacy and confidentiality. We recognize that the quality of the data directly impacts the use of the data. With the addition of benchmarking and comparators, the quality of the data across all organizations, practice groups, and programs must be tracked and maintained. Our goal is to ensure that data entered into the BIS is timely, accurate, comparable, as well as usable and relevant for all stakeholders. The BORN data quality framework is based on 5 dimensions of data quality, which in turn are divided into 19 elements and sub-elements. So I'm briefly going to go through each dimension that's on your slide. First, timeliness is how current or up-to-date data is at the time of release and whether the data is available for user needs within a reasonable time period. Accuracy or validity is how well information within or derived from the database reflects the reality it was designed to measure. Comparability or reliability is the extent to which data are consistent over time and entered using standard conventions, making it comparable to other databases. Usability is the ease with which the data is understood and accessed. And finally, relevance is the degree to which the data meets the current and potential future needs of users. Assessing the fitness for use of information in the BIS involves adequately managing each dimension. The building blocks for this framework require that the data be as current as possible so that decisions are made with recent information, be accurate and entered using consistent conventions to ensure its comparability to like data, be accessible and easy to understand, and finally, meet the current and potential future needs of the users. If these 5 dimensions of data quality are achieved, user decision-making will then be based on current, valid, reliable, and relevant data. Feel free to also visit BORN's website to see the complete data quality framework. The BORN Information System also brings this framework to bear using a number of features and functions, some of which are built into the BIS. So here I have a few examples. So BORN data entry guidelines, near real-time data entry is always encouraged. We have drop-down lists, which minimizes free text. We have mandatory fields and data validation rules, where missing data is minimized. And we also have point of entry validations, such as automated algorithms. For example, an OHIP number has to be the appropriate length and format. We have many consistency edit checks, like verifying if an intervention can only be one type of answer. Dual entry of variables, data capture quality control measures. We also track missing data, which are identified in many reports and created in the BIS. We have data saved in a secure location, protection of personal health information and controls on data access. We have pre-population of data, which improves consistency and reduces duplication and error. We have linkage of cases, which are across encounters and to other data sets. And finally, feedback mechanisms and support, which are our BORN coordinators and our help desk. Finally, our BORN committees provide advice about changes for any of our data elements. So these are a few tools to enhance quality. We have webinars, such as this one, briefings in deployment. We use them for training and for enhancements. We also have site visits, which are done one-on-one, thanks to our coordinators. And we have other tools, such as teleconferences with DQ managers, reference guides. We have field-level help, page-level help, which is built into our BORN information system, and our BITS bulletins. Other resources are our 24-hour help desk, which is available via email or telephone, and of course the BORN website, where you'll find our data quality framework and summary, as well as training guides, our data dictionary, and plenty of training videos. So now I'll pass it back to Heather, who will give you an overview on congenital anomalies.
Thank you. Since our audience has varying expertise, I will offer a brief refresher on congenital anomalies. There are many variations of the definition for congenital anomalies. This is also synonymous with birth defects, congenital abnormalities, and congenital malformations. But the definition here, so I have to also give credit to them, as well as for the information in the next few slides, was taken from the World Health Organization, United States Center for Disease Control and Prevention, CDC, and the International Clearinghouse for Birth Defects Surveillance and Research Surveillance Manual. Congenital anomalies are defined as abnormalities of body structure or function that are present at birth and are of prenatal origin. These can be structural or functional anomalies of organs, systems, or other parts of the body, which can be caused by genetic or environmental factors, or both, and can be evident before birth, at birth, and show up later in life. The three components of structural anomalies include development, health impact, and presentation. I'll just briefly touch on all three of these. So the development of structural anomalies includes malformations, which are associated with tissue that is abnormally or incompletely formed or may fail to form altogether. Malformations often occur in the first trimester, and examples include spina bifida and cleft lip and palate. Deformations are conditions arising from unusual force or stress on a normal tissue, and this is causing abnormal shape. Deformations are often occur in the second or third trimester, and an example would be clubfoot. Disruptions involve the breakdown of normally forming tissue. An example of this would be the amniotic band constriction or sequence. A dysplasia is a disorder at the organ level that is due to problems with tissue development. An example would be achondroplasia, which is a common cause of dwarfism. Although structural anomalies should be classified in one of the four types, the term malformation is commonly used in daily practice and often in literature as a generic term to include all four types. As for health impact, major anomalies are defined as the structural changes that have significant medical, social, or cosmetic consequences for the affected individual and typically require medical intervention. Major structural anomalies are conditions that account for most of the death, morbidity, and disability related to congenital anomalies. As reported in the Public Health Agency of Canada Congenital Anomalies 2013 report, major congenital anomalies occur in approximately 3 to 5% of newborn infants and 8 to 10% of stillbirths. In contrast, minor congenital anomalies, although more prevalent among the population, are structural changes and pose no significant health problem in the neonatal period and tend to have limited social or cosmetic consequences for the affected individual. Some examples of major anomalies include spina bifida, transposition of great vessels, cleft lip, and gastroschisis. Examples of minor anomalies include fused eyelids, misplaced ears, overlapping toes, and tongue-tied, as well as the others listed. The clinical presentation of anomalies includes isolated, multiple, isolated sequence, and syndromes. About 75% of major congenital anomalies occur in isolation, meaning that there is no other unrelated major anomalies present. However, frequently isolated major anomalies are associated with one or more minor anomalies. A multiple congenital anomaly is occurrence of two or more major anomalies that are unrelated. This means that the major anomalies are presumed to have random occurrence. A sequence represents a cascade of events that are known or presumed to have derived from a single primary anomaly or factor. In contrast, a syndrome is a pattern of multiple anomalies thought to be related, but not representing a sequence. They are due to a single cause, genetic or environmental, or a gene-environment interaction. When multiple effects occur in a specific order, it is known as a sequence. When the order is not known, it is a syndrome. I guess to make it simple. The other type of defect is functional anomalies, which include developmental disabilities, metabolic disorders, and inborn errors of metabolism, as well as hematologic diseases. And some examples are listed here. When establishing a congenital anomaly surveillance program, the initial anomalies that are generally included are major structural anomalies that are readily identifiable and easily recognized on physical exam at birth or shortly after birth. And these generally include the orofacial clefts, neural tube defects, abdominal defects, and limb deficiencies. Just a few additional comments based on the World Health Organization fact sheet. Although approximately 50% of congenital anomalies cannot be linked to a specific cause, there are, however, some causes and risk factors. Socioeconomic factors are one. This may be an indirect determinant. However, congenital anomalies are more frequent among resource-constrained families and countries. Genetic factors, particularly consanguinity, which is when there is a relationship between blood relatives, increases the prevalence of rare genetic anomalies. Maternal infections are a significant cause of birth defects in low and middle-income countries. Maternal nutritional status, such as folate insufficiency, obesity, or diabetes, are linked to some congenital anomalies. And maternal environmental exposure to pesticides, medications, alcohol, tobacco, and other substances during early pregnancy have increased the risk of a fetus or infant being affected. Preventative public health measures taken during the preconception and prenatal period can decrease the frequency of certain anomalies. Primary prevention includes improving the diet of women, particularly folic acid intake, and abstaining from harmful substances such as tobacco and alcohol. Controlling diabetes, avoiding exposure to hazardous environmental substances, improving vaccination coverage, and increasing and strengthening education are also key to prevention. Screening and detection of anomalies can also be conducted during several periods in the pregnancy. Now we'll continue on with what surveillance is and our national and provincial programs. In general, surveillance is defined as the ongoing systematic collection, analysis, interpretation of data for health purposes, and the timely dissemination of health information for assessment and public health response. Surveillance also allows for the planning, implementation, and evaluation of health strategies and uses the data to help prevent adverse health conditions. Surveillance in congenital anomalies should also involve a systematic review of birth outcomes to determine the presence of congenital anomalies and have the capacity to link risk factors such as maternal exposures during pregnancy. Our federal program is called the Canadian Congenital Anomaly Surveillance System. Pretty much from now on, I'll be calling that CCAS, and is managed through the Public Health Agency of Canada. CCAS is an important component now of the Canadian perinatal surveillance system. It was first established in 1966 in response to the thalidomide tragedy. The CCAS provides national data on the prevalence of congenital anomalies, which, as I stated, are the leading cause of infant mortality, morbidity, and lifelong disability in Canada. In 2008, the Government of Canada announced the Action Plan to Protect Human Health from Environmental Contaminants. Now, under this federal initiative, PHAC leads activities towards enhanced national surveillance of congenital anomalies by collaborating with Canadian provinces and territories. Specifically, resources are being used to enhance established surveillance systems, but also support the development of new systems where there are currently none. This is a little busy slide, so I'm not really going to go much into it, but the initiative has ongoing funding of $1.7 million annually. Not all provinces and territories are part of this initiative, as you can see by the timeline on the bottom of the slide. The province and territories generally have unique programs, but similar challenges exist, which include adequate funding, government legislation and restrictions for ongoing surveillance in the provinces, privacy barriers, and data collection. As was said at the beginning, these will be published, so you can look at more information if you want later. Just wanted to note that the Northwest Territories are taking a different approach to surveillance and requiring all newly diagnosed cases of congenital anomalies reported under their new Public Health Act. So congenital anomalies have become a notifiable disease. And this is a pamphlet that they have published with just an example of what they are hoping that will be reported to them. Alberta is a province not currently part of the federal initiative. However, the Alberta Congenital Anomaly Surveillance System, ACAS, is one of the most established programs since about the 1980s and has reported data to world organizations for decades. BORN has looked on this program as we begin this initiative for guidance, especially in regards to our reporting framework. Currently, the federal surveillance model has CCAS receiving data from CIHI, in which receives data from the hospitals, and then doing data processing, analysis, and reporting. The proposed future model would be for CCAS to actually receive congenital anomalies data directly from provinces and territories. It should be known that Ontario is currently one of only a couple provinces actually transferring data from BORN and the BIS directly to PHAC. And if interested, the Public Health Agency of Canada has put out this report entitled Congenital Anomalies in Canada 2013 Perinatal Health Surveillance Report, and can be accessed at this link. Now turning our attention to the Provincial Surveillance Initiative. As most of you know, this is the landscape of Ontario. Geographically, Ontario has a population of over 13 million, with Canada's most populous province, including the second largest province by a total area. Approximately 94% of the population is concentrated in the southern region, and 85% of the population live in urban areas. In regards to our health system, there are 99 birthing hospitals and 84 midwifery practices, which care for the 140,000 births per year. Over 95% of the deliveries occur in hospital, and then about 1 to 2% at home, and the remaining 1% occurring in birthing units as of this 2013, and the catch-all other. Ontario also provides prenatal care, screening and diagnostic clinics, has 6 maternal fetal medicine units, and other specialty clinics. There is universal provincial health care, and all individuals are provided a unique identifier. I just wanted to note that even with the moderate calculation at 3% for major anomalies, Ontario would expect over 4,000 anomalous pregnancies, which is actually more than the birth rate of most of the other provinces and territories, as noted in the other slide. So we do have a lot to look forward to. The objectives of the Ontario Surveillance Initiative include, obviously, one, maximizing the ascertainment of congenital anomalies data, as well as enhancing the BIS to accommodate additional data sources and improve data quality. Identifying and developing methods to assess the environmental effects and examine the appropriateness of care for women diagnosed with fetal anomalies to facilitate improving the quality of life for infants living with congenital anomalies and their families. And finally, continuing to communicate project progress to PHAC, CCAS, and BORN stakeholders, which includes the Ministry of Health and Long-Term Care, the BORN Ontario Congenital Anomalies Committee, BORN Maternal Newborn Outcomes Committee, and of course yourselves as the users. So Ontario's surveillance program can be characterized as a population-based system which captures all birth outcomes with anomalies whose maternal residence is Ontario. The program utilizes active and passive case ascertainment, and we use multiple data sources. Cases are defined as pregnancies with one or more of the selected suspected or confirmed fetal or congenital anomalies, with a pregnancy outcome of live birth, stillbirth greater than 20 weeks, and terminations for fetal anomalies following prenatal diagnosis. Cases are captured in the BORN information system if diagnosed prenatally and currently up to discharge from hospital. The BORN information system has provided the Ontario Surveillance Program the ability to successfully integrate and collect data, which includes anomaly and anomaly-related elements, into a single registry since 2012. The fetal anomalies collected in the BIS come from the prenatal screening and antenatal specialties encounters. Congenital anomalies data is collected in the birth child, postpartum child, NICU, and newborn screening encounters. This is just a quick pictorial of where the newborn anomalies are collected in the BIS. Once one chooses a suspected or confirmed identified anomaly from the child encounter or any of the other encounters, the parent list is available and expands out based on your selection. So you can see here I clicked on abdominal wall, and you have the selections, and this would be similar for all others, as well as the option to pick none and unknown. And this was supposed to not show the other one till after, but so this was just a quick demonstration of the BORN data dictionary. but we'll have this corrected before we publish them, so that you'll actually be able to see how you can search the Born Data Dictionary online for words, say, like encephaly, and you will see the encounter, the newborn congenital anomalies encounter that it's available in, and then the encounter. And if you choose that, you would see the pick list options for that word. So if you're not exactly sure if it's a head brain or if it's under syndromes or other, this would be a spot to actually be able to go and check that information. The anomaly pick list, as you know if you're a user, is quite extensive and collects major and minor anomalies, irrespective of their health impact. All anomalies are collected, but due to the large number of births in Ontario, Born Ontario will be focusing reporting efforts on major anomalies at this time. Other program highlights include securing an additional 10 years of funding for this project and transferring the Born data sets since 2009 to PHAC for the national core variables. Born has also developed data quality reports in the BIS to validate data and to improve the completeness and quality of reporting of fetal and congenital anomalies. Born has obtained data sets from CIHI for anomaly and termination data for the last 10 years and has performed record matching and compared CIHI and BIS data sets. Now I'd like to pass it off to Erin, who will now talk about our data quality.
Thank you, Heather. I will now cover some of the data quality in the BIS to build on what both Chantal and Heather have covered in this presentation so far. So to start, I'd like to talk a bit about what data quality means in the context of the anomalies that we're collecting. So in order to assure data quality in this particular subset of our elements, for this, high quality data means a high level of case ascertainment or sensitivity. This involves ensuring a minimum number of false positives or non-cases existing in our registry, and that anomaly classification, when needed, is very specific. So methods for achieving this high quality of data include using multiple sources, so that would be bringing together different encounters as well as outside data sources and bringing them into the Born information system, developing standard procedures with validation and classification to support this, having documentation available to those entering the data to ensure it's done consistently and correctly across all sites. So this can involve flowcharts, processes, procedures, and of course our data dictionary. It's also important to have the appropriate personnel with both the number and having the right qualifications in order to ensure our data quality is as good as it can be. So to start, I'd like to look at the 2012-2013 Born Information System missingness for our newborn anomaly data. So within our data element, within our data, we have an element called the newborn anomaly identified, which is a yes/no indicator. And of this, we had over 3,000 birth records that identified anomalies in the BIS for this year of data. Of those, approximately 7.5% were missing data for both the newborn anomaly confirmed and the newborn anomaly suspected. It's important to keep in mind that this really is only 280 births in our system, however. Additionally, there were another 500 birth records that were missing data for one of the anomaly's data elements, suspected or confirmed, but where none was selected for the other. So this would be a case where the flag, the newborn anomaly identified flag indicated that there was anomaly, and perhaps the suspected anomaly was selected to be none, but the confirmed anomaly was then left blank. So this is just to show you a visualization of this. What this is by the different sites in Ontario for each hospital. This is the percentage of missing elements we have for the confirmed congenital anomalies data element. So while this graph looks quite big, it is important to realize that this represents a fairly small number of overall records. However, you can see with the average there of 39.7% missing, and this is the total missing, not just for those records where the indicator flag was identified as yes for an anomaly. This can be missing whereby the newborn anomaly identified flag was selected as a no, and then the other elements were not filled out. And that's how those percentages don't line up exactly. Also, for the newborn anomaly suspected variable, which is similar, the pattern looks quite similar to this graph. However, the overall missing values are quite a bit lower at 20.4%. For this next portion of the presentation, I'd like to compare a few sentinel anomalies, what we have in the Born Information System for 2012 and 13, compared to what the Public Health Agency reported in their 2013 Congenital Anomalies report. So for the first anomaly I'd like to look at is Down syndrome. And so on this slide, I have the Ontario Down syndrome rates. The first gray bars on the left represent the confirmed only anomalies, and this is 2012 first, followed by 2013. The middle, lighter orange bars represent our born data, a combination of confirmed and suspected anomalies. And finally, the far right, darker orange bar is Public Health Agency's estimate. The latest they had available is for 2007, so keep in mind that these time frames are not identical throughout the graph. Now for this one, you can see we do have, when we combine the confirmed and suspected rates for born, we do get very close estimates to what the Public Health Agency is publishing for our Born Information System for Down syndrome. On the next slide, I have the similar setup, but for gastroschisis. All of the columns are in the same order with the same coloring. You can see for between 2012 and 2013, we've improved in the confirmed only capture of this anomaly. And you can see, as would be expected with gastroschisis, we have very similar rates between confirmed only and confirmed and suspected. It's quite nice to see that in this particular anomaly. To keep in mind also with that comparator group on the far right, however, is that the Public Health Agency has done a combined rate between 2002 and 2009. So this is a 7-year average for Ontario, which could be why it differs a bit from what we have in our information system. For this next slide, this is looking at the limb deficiency defects rate for Ontario. All of the columns are in the same order. You will see, however, that the Public Health Agency does an average between 1998 and 2007. So there's a variety of reasons why this could be for this difference in rates. One of them is that there are quite a lot of sub-anomalies that go into this categorization. And these sub-anomalies, some of them are a bit more minor and we think might be a little bit trickier to pick up in the Born Information System with the data capture that we have. The final anomaly I'd like to look at is cleft lip with or without a cleft palate. And so for this one, you can see the same columns in the same order. We're doing fairly well with this capture as well. You'll notice that, however, my comparator group for this one only covers Canada. They didn't calculate an Ontario-specific rate in the most recent publication for this. And again, we wouldn't necessarily expect the Canadian rate to be equivalent to the Ontario rate. So after having taken a look here at some of the data that we have available and what we are collecting in the Born Information System, while our rates are generally quite good and comparable to the Public Health Agency's estimates, there is still a lot that we can do to improve the data quality in the BIS. So what can hospitals do to help? We do rely on the data that is submitted by hospitals for the newborn anomaly flag in order to complete our surveillance. So ensuring that your data is as complete as possible when you're entering it, and to pick the none option for infants without anomalies helps us to do this as effectively as we can. We'd also like to hear from you, however. What can we do to help you to get this data entered into the system? We're finding that there are some gaps in the information we have with that varying level of missing data by site. If there are things that we can be doing to make this easier for our sites to enter, we're quite interested and would like to have that conversation. over the next few months, we will be asking your coordinators to start a conversation with you about congenital anomalies data quality. We will provide your coordinators with site-specific rates, estimates of the cases that may or may not have been missed, and from you, we'd then like to hear back what barriers at your site could be to entry and what we might be able to do to assist with collecting this data. In terms of next steps for us at BORN with this project, we're looking to increase our ascertainment of anomalies by increasing our capture of stillbirths and terminations in the BIS. We'd like to increase the number of anomalies that are recorded as confirmed instead of suspected, if possible. And we're also looking to publish a report on the data quality that we do have in our anomalies data so that it's available for use more widely. I'd also like to thank and acknowledge the Ontario Congenital Anomalies Committee for their work to date for this portfolio. They've been very helpful in our data quality and in helping us find the right direction for our projects and the work we're doing. And now that ends off our presentation. I'll hand it back to you, Kathy.
Okay, thank you. So I'd just like to thank all three of you, Heather, Erin, and Chantal, for a great presentation. And I'd like to remind everyone that if you have a question, please type it in the chat box at the bottom left hand of your screen, and we'll be happy to answer those for you. So while we're waiting, I just had a quick question for you, Erin. The rates of Down syndrome, gastroschisis, and limb deficiency that we saw in the bar graphs, so are those live births and stillbirths or just live births?
For BORN, that is a combination of live births and stillbirths. So It is important to note that public health agencies, some of those are live births, and I believe some is a combination too.
Great, thank you. And fetal loss so far is not included in those numbers for BORN?
No, not for this one, because of the work FAC has done to date was focusing largely on the live births. We didn't pull in our fetal anomalies data so far.
Right.
That will be in our future work, though.
So a few questions in our chat box. Could Erin comment on the comparison between BORN and CHI data for major anomalies? And that's from Anne.
Okay, sure. So in a comparison we did with a direct record linkage between the CHI DAD and our BORN information system for 2012, we were able to calculate very comparable rates for most of the major anomalies. We did this based on categories that we had created called our core anomalies group, which I'd be happy to share with anyone if they're interested. So, but we were able to find that our rates were quite comparable in those categories. Still to do on our list is to make comparable groupings to what's used by CNN and the sentinel anomalies reported by the International Clearinghouse and Alberta, to be able to compare more directly with CHI and with those other sources on those anomalies.
Great, thank you. So I don't see any other questions in the chat box at the moment, but maybe we'll give it a few minutes here. Here's a question from Karen. It says, do you have any estimate of rates of missing information?
We're still working on that. So what we're looking to do is with these new groups of congenital anomalies, the major and also the sentinel anomalies, we're hoping to use the CHI data to estimate what we may be missing and calculate that information. So right now we can say that we're kind of within the realm of error of the estimates we get for most of the major anomalies with our calculation, but we'd like to be a little bit more specific and be able to go and calculate rates by record on a record by record basis, and also match those records between the BIS and the CHI's DAD to see if we had the same anomaly on that same record. And we're hoping that that will allow us to calculate a very specific rate of missing information for our database.
That's great. Question from Dr. Aideen Moore. Any idea on why there is difficulty obtaining data when an anomaly is confirmed?
It's Heather. I think this goes a lot to just what is being able to be entered at the hospital sites and what I guess they feel comfortable entering. If it's confirmed, a lot of places, because they're being discharged, we're only collecting up to discharge. They might not actually have a specific confirmation, so they're putting it as suspected. I believe, a lot of these anomalies need chromosomal or different testing, so I think a lot of sites feel it's more comfortable leaving as suspected, and we need to work on moving that over with additional data sources, as we talked about, or just maybe the comfort level of the hospitals doing the entry.
Thanks, Heather. I just wanted to reiterate what Erin said, that if you can relay to the coordinators on what we can do to help you to enter the data, the coordinators would be happy to share that information with this team. No other questions in the chat box at the moment. Another question here now. It says, for the 1,338 newborn screens that were missed, do we have any idea how many babies were subsequently screened due to follow-up from born? So I think the question's asking potential missed screens versus true missed screens.
And Kathy, you believe you were speaking to Shelley about this. Is there any way you could answer this, or Anne, or
somebody that's unmuted? So I think the operative word is potential misscreen, and that all 1,300 babies were not necessarily missed, but might have gotten missed moving between hospitals, moving between NICUs, moving between mother-baby units into an NICU or an early discharge. So not all of those babies were misscreened, but they were flagged as not having their newborn screening done, and then follow-up was done from there.
According to our screening specialist, Shelley Dugan, who gave us a little update, she said a lot of these, they were identified as possibly being, as Kathy said, missed, but some of them might have declined the screening, or had the screen had to actually be redone because of not a sufficient blood. So we can actually maybe, Tilly, I will try and get a little bit more information for you, and I'll get your information and pass along something that Shelley Dugan has wrote up.
That's great. Thanks, Heather. Just waiting for any more questions in the chat box. We have a few minutes left. Don't see any more questions at the moment. Just while we're waiting, I'll move on to two brief announcements. One is about our Born conference. So Born is hosting a 2-day conference, the right information in the right hands at the right time, using data to improve maternal child care and outcomes. It's on February 6th and 7th, 2015 at the Fairmount Chateau Laurier in Ottawa. The call for abstracts is open, and the Conference Program Planning Committee invites you to submit an abstract for presentation. The deadline for the submission has been extended to Friday, October the 24th. And if you'd like some more information about our conference, please visit our website at bornontarioconference.ca. I'd also like to give you some information about our next scheduled Born Provincial Rounds. It will be on October the 16th, and we'll have Becky Blair, a registered dietitian from the Simcoe Muskoka District Health Unit, and Jessica Denning, an epidemiologist from the region of Waterloo Public Health Unit, presenting on the new Public Health Core Indicator, gestational weight gain. So we're really looking forward to that presentation. I don't see any more questions in the chat box, so I'd like to thank our presenters again. Thank you so much, Heather, Erin, and Chantal, for an excellent presentation. Thank you for your review of congenital anomalies and helping us to understand the provincial and national congenital anomalies surveillance initiatives, as well as the collection and data quality of anomalies in the BIS. So again, thank you to our presenters, and thank you for your attention. We look forward to seeing you back again on October 16th. Bye, everyone.